much. We shall go on to our next speaker, Dr. BHAURA, who is a very eminent, highly respected ophthalmologist from Jalandhar, Punjab, and the medical director of the Akhal Eye Hospital. And he has a learning tip for us. So on to you, Dr. BHAURA.
Thank you, Dr. Madam Chitra, for giving a chance to be part of this wonderful teaching program. Good afternoon to everyone. I'm going to present a case of pre-existing big tear, pre-existing. The patient didn't have any history of trauma. And I've seen only 2 cases in my life of 25 years of phacoemulsification in such 2 cases, where they are the mirror images of both the cases, a mirror image of tear. So I'm going to present a short video, very highly edited video. Can I have the video? To start with, please see the tear, pre-operative tear, which I have marked.
Dr. BALBIR, should we share the video?
Yeah, we'll share. We'll do that only. Just come up. Stop. So, yeah, stop. Here, I think you can see those arrows marking the pre-operative tear, which have been diagnosed pre-operatively on the slit lamp, and even on the slit lamp under retroillumination, I could see very clearly. So basically, so capsule access, which is not difficult. The lens is not very hard. The cortex is also very soft, and a good capsule access is being done as usual. So here, that's the point. I'm not allowing the fluid to go behind. It is only in the interior, under the interior capsule, I am putting some fluid. I'm not allowing the fluid to go behind because I know there's a big tear, and I can see the outlines of the tear. So to make it easy, removal of, so a little bit of creating a crater in the center. Now, basically under low parameters, I will be removing the nucleus and the cortex from outside inwards with the moderate vacuum but low power. So it's from outside to inside. I'm trying to remove the soft cortical nuclear and epinucleus with phaco tip. It is under topical anesthesia. So shortly you will see very clearly the margins of the tear, and the tear extending from limbus to limbus. And this was similar in 2 cases which I have come across in my life. So little bit of, I'm sorry for the decentering. So yeah. Now with the bimanual irrigation aspiration, again I am trying to remove epinucleus from periphery to the center, avoiding the central part, and trying to remove the epinucleus away from the tear, which is very clearly demarked. The edges of the tear are thickened, which you shortly see after this. And I think we have started seeing also exchange. See. So you can see the tear which are pre-operatively marked by me by arrows. It corresponds to the post-operative tear. And you can see from end to end, from limbus to limbus, big tear, which I again repeat, I had 2 cases, similar tears, similar situation, similar surgery I did. Now you can see, so again you can see very clearly the tear margins extending, the tear now I'm inflating the bag in the peri from the, so these were the pre-existing tear edges which have been confirmed now post-operatively. So I'm going to put a single piece IOL into the bag. because of my biometries, and I know I will be able to put a single piece in the bag because the tear has got thickened margins, and I don't think it will increase. The vitreous did not present much into the AC, but however, I did vitrectomy, interior vitrectomy, and I confirmed with the tram salon. The postoperative results were extremely good. So at the end, after little vitrectomy, I'm trying to confirm with the tricot. So finally, irrigation aspiration is with the vitrector only. Now you can very clearly see the tear, a big tear, which I've seen in 2 cases, and this one is being presented. The pupil is round.
Yes, a great surgery, Dr. BHAURA, very confident way of dealing with the problem. But there are certain questions, and I'm going to ask this to Dr. Rohit Om Prakash. Now, I do know that we wouldn't do a hydro in these cases where there is a pre-existent PCR, and he has created a larger rhexis. But I don't know how he was able to so comfortably without doing a hydro, would have got the carousel out the nucleus, and the epinucleus would have been quite a challenge for him. And how could he insert the IOL, because it's a vertical split, and he has taken the injected the single piece. How did he align it with this kind of a vertical split? Although yes, if this is a fibrosed PCR, you do believe that it won't easily extend. But I would have been more planned for a 3-piece IOL in the bag with an optic capture. So Dr. Rohit Om Prakash, what would be your thoughts be?
Yeah, I think Dr. BHAURA is one of the most prolific and experienced surgeons in North India, and his surgical skills were there to be believed.
Yeah.
You know, as far as I am concerned, I would not have gone in for a large rhexis. I would have gone in for with an oval rhexis for that matter. If I am not a follower of an oval rhexis, I would have made a 4.5 or 4.6 millimeter rhexis, wherein, if required, I could do an optic capture, because that is something which I would be aiming at when I would be planning to do to make a rhexis with the mind to have an optic capture. I would be wary of my basic concept with which I move is that if my posterior capsule is not round, I somehow try to round off the posterior capsular margin. If I cannot, then I use a multi-piece and I try to do an optic capture, because I have seen that at times it's an unstable situation, and you can, while implanting also, and later on also, there can be some dislocation of the intraocular lens also. But how we positioned it vertical to the anterior, to the posterior capsular tears, with that, and using the hook to flex it and just lie at 90° to the axis of the posterior capsular tear, that could be tried, but not for new surgeons who should be going into all these things.
Yes. Yes, I agree, Dr. BALBIR. You did a very graceful, phenomenal surgery, but it is a surgery which, with experts like you who can be very confident of dealing with placing IOL in such an extensive PC tear. It's a kind of confidence that you're so sure that your manipulation is going to be so very appropriate that it's not going to extend the rhexis. And I don't think the younger people should challenge themselves. It is better to do an optic capture with a 3-piece. Anyway, kudos to you for having done a very difficult, challenging surgery.